Great. All right. So as Tony mentioned, we're here to kind of talk about leveraging behavioral economics and health information technology in your practice. And usually just I start with noting I have no relevant conflict of interest to disclose. Our objectives for the talk today are to identify the foundational concepts of behavioral economics, discuss the unique role of us as pediatric clinicians, those who work in pediatric settings, in motivating parent behavior change, and discussing how to leverage key strategies with health IT in clinical practice to improve child health. Let's start with an overview of behavioral economics. And this is really just a talk that kind of hopefully will pique your interest in this area. I am kind of a burgeoning expert in this area. I really encourage you to, if you want to learn more, to one, check out a really engaging book called Nudge, if you haven't read it already, by Thaler and Sunstein. And then colleagues and I, including Alex Fix, we wrote, so a shameless plug for our work. We had a piece published in Academic Peds last year focusing on how we can apply these concepts to the pediatric healthcare setting. I also like to start with kind of just two kind of jokes from Dilbert, just to help you understand. Many of the concepts I'm going to talk about today, I think people already understand. They just haven't been referred to in a certain way. So as I can't gauge the audience right now, I'll just kind of point out real fast. The first comic talks about, if I quit, I'll lose some unvested stock. That's why I'm willing to suffer my job. And the garbage person, who tends to be the philosopher in this comic strip, the normal brain irrationally puts more weight on a small loss and a huge opportunity. But now that you explained it, now you're just stupid. So a little cruel, but that captures the concept of loss aversion, which we'll talk more about. And another one is Dilbert with his manager. Studies say your happiness depends on how well your life compares to others. So instead of giving you a raise, I'm going to show you pictures of people who were attacked by bears. Do you feel better now? Dang it to heck, this is working. That's an example of reference dependence. So we'll go into more of those examples, but I think nothing like comics to kind of capture in a quick way these core ideas. So really, what is behavioral economics? Well, it's a field that combines concepts from economics and psychology to better understand decision-making. And one of the core contributions of this field has been identifying that humans, we all are predictably irrational in how we approach our everyday decision-making. There are core concepts that have been identified, like loss aversion, weighting losses more heavily than gains, reference dependence. We don't think in absolute terms, we tend to think in terms of how one thing compares to another thing. We have a status quo bias. We tend to kind of make a decision and then just stick with it, even if better decisions come along the way. And we have a present bias. We focus on short term and not the long term, right? Anyone who deals in healthcare or with anybody sees all these things pop through on a regular basis. And the idea within behavioral economics is that we can study these and help people by understanding the typical errors people make. We can help guide choices using a variety of different options, really referred to as choice architecture, to help people make choices that are more consistent with their actual long-term interests. So why behavioral economics? Why is this so important? This is a figure adapted from New England Journal from a couple years ago, but it remains relevant. The idea is this is showing the proportional contribution of premature death in the United States. And what it's showing you is that the vast majority of death, more than 40%, 50%, 60%, are not really related to underlying genetics, that we were kind of predestined to have something happen to us. Instead, it's a combination of social factors, but really behavioral patterns, the choices, decisions we make on a regular basis that contribute to disease. And what do I mean by that? Well, when you look at the top risk factors for premature death in the United States, this is adapted from a publication in JAMA, and this concept comes out, it's every 10 years. You see the vast majority of death in the United States are from tobacco, diet, alcohol, and drug use. Not things that we feel like we always face in pediatrics, but when you scratch at the surface, we do. We deal with diet and obesity, we deal with parent tobacco use, and we deal with kind of the burgeoning patterns of adolescent drug use, these patterns that emerge in their teenage years that then have consequences into adulthood. And so the whole idea is we can do better. We can design situations in a better way. We can improve the choice architecture to help people make better decisions. If anyone has seen any behavior economics talks given before. This is a picture that colleagues at Penn like to use, and I think it captures it well. You have people, two able-bodied individuals who want to go to the gym, so they're presumably going to go work out, burn off calories, and rather than walk up the stairs, they're taking the escalator, right? Just kind of a small, pithy example of they're not necessarily making the best choice right now. So I want to start with, before we get into how we can apply these in kind of healthcare settings, one study that was really important, that really opened people's eyes to the potential of this work. And it wasn't in healthcare, it was in financial savings. And this was the work for which Richard Thaler recently won the Nobel Prize. Let me just give you a little context about what this study was and why it was so important. What they did was, they focused on retirement savings at a company. The vast majority of people want to save more money in the future for retirement. So what they did was, for all new hires, they gave them one of three options. They started with meeting with a financial consultant, and then that financial consultant offered them one of three paths. They could say, well, what you really should do based on the best evidence is where your retirement is right now, you should bump it up by 5%. That will help you in the long term. That would be kind of one option. Another option was to join a program called SMART, which I'll talk about what that did. And then the third one was kind of not pay attention and do your own thing. The SMART program was, the whole idea is that, well, let's start low with what you currently have. And then every time you have a pay raise, we will bump up your contribution into your retirement until we met some predefined amount. And they found that when they offered those to the individuals, the vast majority, 50%, more than 50%, chose the SMART program. About kind of a third chose the just make their kind of, they'll do their own thing. Another third chose, or another 20% chose, well, I'll follow the consultant and I'll do the 5% increase. And what this is showing you on the screen, the three groups by color. The light gray was the group that did their own thing. They did their own thing, and they actually bumped up the first time they put money in more than people typically put in. But as you see over time, over the 5-year intervals, they never changed the percentage they were actually putting in. The group that listened to the consultant and bumped up 5% the following year, they did that once, but they never made any long-term changes. The SMART program, and this was the ingenious idea, they actually contribute a small amount to start, and then they dramatically, over the 4-year, 5-year period, contributed a significant percentage of their income into retirement savings. And the reason why this was so smart, it played off of people's natural cognitive biases. People kind of discount the future. So they like the idea of making a decision that they bump down the road, but they don't actually have to make today. It was kind of preset for them, so they agree with that. It also kind of focused on loss aversion and reference dependence. People don't like putting money into retirement because they're afraid they're taking a chunk out of their paycheck that they're not dealing with. By essentially always seeing the same amount in your paycheck with each pay bump, people felt that was a good approach, and they were actually putting money away into retirement. Again, this is the work that Richard Thaler won the Nobel Prize for, and it's estimated this helped an additional savings of more than $30 billion in automated savings in the United States. They're huge, but this got a lot of attention. Well, let's focus more on things that are related to kind of public health and healthcare. This is a study that kind of makes the rounds when people talk about behavior economics. It was just looking at applying this to public health, taking an opt-in versus opt-out approach when people sign up, get their license, and then sign up to be an organ donor. All the bar graphs on the right show the countries that take an opt-out approach. Most people, in fact, the vast majority of people, want to be organ donors. But when they're faced with a decision, life gets in the way and they decide maybe not to be. What the whole idea here was that you would pre-select the box to have people opt out of being an organ donor, compared to a typical approach of you select the box, which is what you're seeing on the left. What was really striking about this, Germany and Austria are very similar countries, very similar culturally dynamics. And you see a dramatic difference. When you take an opt-out approach, it leads to almost 100% likelihood that people will become organ donors, which aligns with what people actually want to do. These concepts have also been applied in adult healthcare settings, more so than pediatrics, but we'll talk more about that. They've been applied to smoking cessation, helping people overcome their present bias and kind of focus on the short term using financial incentives, only up to about $750. Multiple studies have identified that can dramatically increase the likelihood that people go on to quit smoking. In fact, 3-fold higher rates. And there are a number of studies that have identified that consistent finding. In terms of prevention efforts, there's been a variety of approaches that show that focusing on the benefits rather than harms of sunscreen use actually increases the likelihood of using skin protection. That's called message framing. We'll talk more about that. And then medication adherence. Incentives for both patients and physicians seem to improve statin use and cholesterol levels. And I think what's really fascinating, you can use this in more, let's say, mundane things like medical appointments. When you use social comparisons, studies have identified there are fewer missed appointments when patients are shown peer attendance rates, meaning something like, hey, you're due to see for your appointment tomorrow. Don't forget, the vast majority of our patients show up 15 minutes early for their appointment. And that sort of messaging actually increases the likelihood that people do that. That's something that's fascinating that gets into the power and some of the pitfalls has been applying the work to end-of-life decision-making. Just to orient you to what I'm showing on the screen here, this was a randomized control trial, which was 3 arms focused on end-of-life decision-making. The vast majority of people, when they're faced with kind of end-of-life decision-making, want to choose comfort care, kind of keeping them comfortable over extending their life by a small amount of time. What this study did was took 3 groups, a control group and 2 intervention groups. The control group had the discussion about end-of-life decision-making, and they essentially were presented a form, and they were told to select the box that they preferred, comfort care or aggressive advancing of life kind of extension care. That's what the red column represents in this graph. The other 2 intervention arms were same sort of paperwork shown to them, but then the box was pre-selected for comfort care or pre-selected for life extension. Now, what you see here is that the pre-selected comfort care led to a dramatic increase of people choosing what they actually want. Before this study, they identified more than 70% of people would actually choose comfort care if they had the decision. But sometimes life gets in the way when they're actually faced with it. Here, the default in that arm actually led to a dramatic increase in use of comfort care. What was interesting for the life extension intervention group, when pre-selected life extension, a lot of people just stuck with the default and a lower percentage of individuals actually chose comfort care. The whole percentage represents the amount of people that actually chose comfort care. So what I'm showing with this is that defaults are powerful. If we use them well, they can help kind of improve the likelihood people choose a decision that's within their long-term interests. But we have to be careful because sometimes it can overcome things that we hadn't anticipated. And there have been limited study in pediatrics. There's been some interesting research that shows that with school lunches, guiding parents and children towards healthier options by how you present the food to them, kind of what's the default option, will increase the likelihood that children and parents will choose the healthy options. Some fascinating research in breastfeeding and safe sleep. A recent study in JAMA Pediatrics found that paying women to breastfeed actually dramatically increased the likelihood they would be breastfeeding at 2-month follow-up by as much as 6%. And there's a vast amount of research in vaccine adherence. So I hope people walk away from, in addition to kind of wanting to be a little intrigued by this and maybe reading more about behavior economics, we at CHOP really do have an opportunity to kind of apply these core concepts, contribute to the understanding of this, and really help improve the care that we deliver by using these kind of core ideas. Now let's talk more about our unique role as pediatricians in the pediatric healthcare space in motivating parent behavior change. As pediatricians, we're uniquely positioned to intervene to guide both child and parent health. Why is that? Well, we're trusted sources of healthcare advice for families, and the vast majority of our parents don't actually go to their own doctor on a regular basis. They typically are in their 20s, 30s, 40s, 50s. They may not need to or have their own physician, but they come to see us, especially in primary care, multiple times per year, depending upon their age, 6, 7, 8 times a year. And multiple studies have identified across a wide range of topics that parents want pediatricians to intervene in their family's health and their health. Think about helping parents quit smoking, helping with postpartum depression, helping connect to resources that help in terms of employment and a variety of other things. So there's a big request from our families to help. And there's something different about decision-making in pediatrics, which is fascinating. In the adult healthcare space, for the most part, it tends to be physician, provider, and the patient. In pediatrics, that's not the case. There are complex and shifting dynamics, right? It's often a triad of parent or parents, parent plus caregiver, child, pediatrician. And a burgeoning group of kind of research studies have identified parents seem to make different decisions for their children than they would for themselves. That's been identified in smoking, how we can frame smoking messages, which I'll talk more about, but also things like seeking out aggressive care for cancer, aggressive use of chemotherapy, for example, with cancer. The vast majority of adults, if they have cancer, would actually choose not to be very aggressive. But when it comes to their children, they're much more willing to be aggressive in the care that they want to get for their children. So kind of fascinating dynamic. And parents have their biases. One of the things that maybe people haven't heard this kind of described this way, but I think those who are in the practicing care space have certainly seen it on a regular basis. There are biases like commission versus omission bias. Commission bias is when parents often emphasize the harms that are caused by their own direct actions, where they often have omission bias. They kind of think about those harms more than the harms caused by not acting, kind of indirectly by inaction. And the classic example is vaccines. Parents are more concerned about the harms from the vaccine, even though they're frankly infinitesimally small in the scheme of things, compared to kind of the harms from not vaccinating their children, which is much more of a real world situation. And what's fascinating, studies have identified that, especially in pediatric settings, physician recommendations, strong recommendations from the physicians can overcome these biases. So this just gives you a sense of kind of the opportunity. So let's talk now more about the key strategies, or some of the key strategies that we could be incorporating into clinical practice. So we talked about how pediatricians were primed for behavior economics. Here are the key concepts: message framing, use of defaults, and use of defaults is typically viewed as one of the strongest ways to help with decision making. Something called enhanced active choice, and then leveraging social forces. How information is presented matters. Just want people to kind of digest this picture for a second. These are from colleagues in the UK, hence the spelling of frozen yogurt. But typically, people are more likely to choose the frozen yogurt that says 80% fat-free than they would the frozen yogurt that says contains 20% fat, even though they're the exact same thing. Think about when you go into the supermarket and if you're purchasing beef. You prefer something that says 80% lean beef than something that says 20% fatty beef. Right? So how information is presented can influence decision making. How a health message is presented matters. And this gets into a core concept in behavior economics of gain versus loss framing. Gain framing focuses on the benefits of engaging a behavior. Loss framing focuses on all the consequences of failing to engage. So this is kind of a crude little comment, but it captures the core point here. When you look at message framing, so the positive frame is, if you donate money, this cute bunny will live happily ever after. Great. If you don't donate money, this cute bunny will die. That's a negative frame. In healthcare settings, multiple studies have identified that when we need to kind of motivate people towards prevention behaviors, a gain frame seems to increase the likelihood that they will do it. So for example, in adult healthcare settings, making a statement like quitting smoking will improve your health increases the likelihood that adult will go on to start treatment to quit smoking and successfully quit. When it comes to screening behaviors, so there's a potential risk there, right, that you might unmask something. A loss frame is actually more effective. If we don't screen for cancer, if we don't get that colonoscopy, we could lose the chance to treat early before it does more harm. And we've explored this concept. There hasn't been much work, in fact, at all in pediatrics, and our research group has looked more closely at this, of using message framing to help parents quit smoking. What we did, what I'm showing you here, is we built a whole bunch of different sort of messages focused on 3 dimensions of interest. Who the message featured, for example, the child, the parent, or the family, how the message was framed, gain or loss framed, and then the outcome. We included an outcome in some of these messages, like preventing respiratory illnesses or cancer, or your child becoming a smoker. And we did something called a discrete choice experiment, in which we put all these messages into a system in which the parent would go through them, see all the messages in an equal number of time, equal number of comparisons, rate what they found to be most meaningful and least meaningful, and helping them start treatment to quit smoking. And this just showing you on the right-hand side a screen grab of what that looked like. We then did this study with 180 different parents, and then took the output of all the different messages. Essentially, what were the ranked ordered messages of what parents found to be most meaningful, stated by their physician to increase the likelihood, stated by their pediatrician to increase the likelihood that they would go on to engage in treatment. And we found fascinating results. And this shows you how we should be investigating these ideas in pediatrics. The message type that was most likely to boost treatment acceptance was pretty much any message that focused on impact of smoking on a child. What I'm showing you on the right side is this relative importance graph showing all the messages and their relative importance. And these are it's a multiplicative range, meaning that a number that's around 7 importance is 7 times more important than a number that's around 1. And what you see pretty clearly in the color coding is the child messages were really strongly preferred, especially much higher when you factor in the outcomes on respiratory health, cancer, general health. Gain versus loss framing mattered, but didn't matter as much as just focusing on a child. So a telling message could be quitting smoking will improve your child's health by preventing respiratory illnesses like coughs, colds, and wheezing. And our evidence suggests that dramatically increases the likelihood that the parent will be amenable, will be interested in starting treatment. So that gives you an example in pediatrics. Now, the next core strategy is the power of defaults. Defaults are sticky, even if there are better choices available, even if other options emerge. And why they're so important, they can guide decisions without restricting choice. You could always kind of opt out of it. And I want to take this quote from that book I mentioned by Fowler and Sunstein Nudge, because I think they say it well. It's their academic statement, but it captures the core ideas. The combination of loss aversion, kind of being afraid of potential losses, with mindless choosing implies that as option is designated as the default, it will attract a large market share. Default options thus act as powerful nudges. That's what they identify within the theory, and there's a lot of research to back this up. I'd like to start with just defaults in everyday life. So, for example, New York City taxi cabs. Back in 2007, 2008, New York City taxi cabs moved to essentially accepting credit cards in an automatic way in all cabs. And what they added with this credit card system was default tipping, which I've highlighted with that pink circle, 20, 25, and 30%, which frankly seems very high to me, but that's what they defaulted. And they looked at this. They actually analyzed the data. Before they went live with this, the typical tip with cash or credit card was 10%. After this, with no real change in the quality of the taxi service offered, the average tip went up to 22%. It was estimated it was 144 million additional tips per year. That's why when you use rideshare apps, you see that default tip that's offered in Uber or Lyft, the power of defaults. Now, they've also been applied in healthcare contexts. This is a study done by our colleagues at Penn, where they shifted the default, and they looked at a pre-posted redesign of default options around prescribing generic medications. What you're seeing is by color codes of the lines, different types of medications for different diseases. Then the hashed vertical line shows when they went live with the EHR, the electronic health record change. And then what that essentially was anytime someone typed in a medication in that class, it defaulted it to the best generic option that was kind of agreed upon by the group. And you see a dramatic increase, almost to 100% for the vast majority of medications, that the generic option was chosen or prescribed more often, just by simple defaults. And what was interesting about this study, an important finding, is that people can still opt out. The orange line represents hypothyroid as a condition. Levothyroxine is a medication often used there. And there's evidence that the brand versions are actually, certain patients respond better to the brand than the generic. And so the physicians, providers knew that for certain patients, and they might have opted out of the default to still go with the brand. And you see that they still have that option. So it was powerful, but people still had the option to opt out. In our space in pediatrics, there's been a lot of great research that has shown the power of defaults to improve vaccine receipt in children. For example, using an opt-out framework of how we present vaccines versus an opt-in. The opt-out framework talks about announcing, or kind of presumptive, your child is due for routine vaccines. I'm just showing you the script on the right if you want to read along what a typical script could look like. Versus an opt-in approach, more participatory, saying your child is due for the vaccines. Are you okay with that? We want to make sure we get that. The opt-out approach was really, the expectation is your child's due for vaccines. Let's do that. Let's move on. That sort of opt-out approach in multiple randomized control trials has been shown to lead to a 5% increased likelihood of the family, the child, receiving the HPV vaccine. That is a really significant, clinically meaningful difference. People have also gone further with the use of defaults in terms of vaccination, going to standing orders. Standing orders are the concept that the order is available, that essentially a nurse or a medical assistant, rather than have a physician, can automatically pull the order and then give the vaccine. And multiple studies have identified that this is an approach that's effective in both adult and pediatric settings. It overcomes barriers in administration, saves time, you don't have to wait for the doctor to put the order, and it increases vaccine rates by potentially up to 20 to 30%, depending upon the area. What I'm showing you on the right is one study that was done out of Denver Health, where they shift to a default combined with a standing order for their vaccines, and they looked at a comparison in the vaccines delivered typically at age 11 at the national rate and then at the state at large. So the blue bar represents national, the light blue bar represents Colorado, the state, and then Denver Health was that kind of dash bar. And what you're seeing is a dramatic increase in the likelihood of receiving those key vaccines when using that combination. And again, the vast majority of parents want vaccines and they can always opt out. But these simple approaches lead to a dramatic increased likelihood that children receive vaccines, the vaccines that, in this case, prevent cancer, for example. Now, the third strategy is something called enhanced active choice. Defaults aren't always feasible or correct. They're best for single optimal decisions, but there are sometimes where you need kind of someone to really make a decision. You don't really know what's the best option for them, and you don't want to default it. So the idea is you can prompt an active choice. When someone's primed to act, you give them a yes or no decision that they have to think about. And what you do is you enhance that by highlighting the risk and benefits of kind of inaction and action. And there's data that suggests it actually increases responsibility and satisfaction because that person who is either making the decision, either the physician or the patient, feels like, I made that decision and yes, I'm going to act upon it. You've still guided them in that direction, but again, it kind of increases autonomy, the feeling that I've led this decision. And the first study that really kind of drew attention to this was kind of a fascinating one, looking at automatic refills for chronic medications at one of the leading pharmacies at CVS. They did a randomized control trial when they had people who were eligible for refills on their medications. The one group received the traditional opt-in for those who ever have to refill medications. You get either a text message, in this case, these were phone calls. It said, press 1, the phone call, you need your refills. Press 1 to talk to customer service. Press 2 to automatically enroll in the future. That we'll handle this in the future. The enhanced active choice said, all right, press 1 for refill your own prescription each time, and they kind of drag that out, kind of emphasizing the downsides of having to do this on your own each time. Press 2, hey, have us, CVS, do it for you automatically. And what they found, when you see the bar graph on the right, pairing these two groups, the key one is the white bar there. In the opt-in group, about 15% of that group refilled their medications on a regular basis. The enhanced active choice group, the rates doubled. More than 30% actually refilled their medications. They did a follow-up study and showed that that enhanced active choice actually also physically picked up their medication at a much higher rate. Those are the power there. This hasn't really been applied in pediatric settings directly, but I think we could design these in interesting ways. So think about a referral to an obesity treatment program or managing obesity treatment. You don't want to automatically kind of refer everyone to a program. That may not be the right choice for many families. So it really wouldn't be appropriate. But instead, you can create an active choice scenario where using tools, electronic health record tools, you identify at-risk children, and then via the physician, the nurse practitioner, the provider, you present the yes or no to referral, and then make sure that information is presented about the pros and cons of action and inaction. And it's not going to work for everybody, but that could lead to a dramatic increased likelihood that our families actually connect to our treatment program, the Healthy Weight program. So just an idea. The fourth and final key strategy is leveraging social forces. And so there are two core areas here, two core ideas here. One is the idea of social supports, in which we leverage existing social relationships in positive ways. There's been some fascinating research that talks about, misspelled there, sorry, peer coaches helping improve chronic care management, when there have been several randomized control trials that identified comparing a peer coach compared to intensive kind of physician support compared to intensive nurse support, show that the peer coaches actually led to an increased likelihood of better diabetes care management in that at-risk group. So an interesting idea. There's also ideas around social comparisons. where we make individual actions visible to other individuals. So for example, New York State was the first to do this. You make public report cards available about how programs do in terms of, for example, their surgical outcomes. And that's been shown to improve surgical outcomes in the long term. And there's work, including work done at our institution, which I'll highlight, in terms of improved antibiotic prescribing. Now, I want to show someone on the right here just to highlight this particular image. People can digest it for a second. This was part of Christakis' group. These were interesting papers published in the New England Journal, part of a series, looking at the social network mediated aspect of disease, looking at smoking, obesity, and depression. And what they were showing is that smoking status looks to be strongly associated between subjects and their social contacts. If you have a close friend, especially a close friend from a higher educational background who quits smoking, you are dramatically more likely to quit smoking. The strongest one is if your partner or spouse quits smoking, you are much more likely to quit smoking. The same sort of work identified risk of obesity and risk of depression. If you have someone in your life who's low risk of depression for whatever reason, you have a lower risk of struggling with depression, similar with obesity. So fascinating kind of idea about this social mediated aspect of disease. Social comparisons are very strong, and we've seen this within our CHOP Care network, how we've been leveraging these ideas. What I'm showing you here is a randomized control trial, a cluster randomized control trial within our CHOP Care network by Jeff Gerber and his group, among others on the phone call, in which they had peer comparisons showing appropriate use of antibiotic prescribing. And what they did was they looked at rates of broad spectrum, essentially the inappropriate antibiotic prescribed for pneumonia at a typical sick acute care office visit. And what's showing you, the white circles represent the control group and the black circles represent the intervention group. And once the intervention started, you're seeing a dramatic decline in inappropriate antibiotics prescribed in the intervention group, in which they had peer comparisons offered to them, essentially about how they were doing compared to their peers. Shows you the power of peer comparisons. And this is another area which I think would be exciting to explore in pediatrics. We really haven't leveraged this. How to best kind of use social comparisons with our families and children. Pediatrics is a naturally more playful environment than adult healthcare settings. We could come up with ways of showing how people get their vaccines or don't. Maybe that's a bad idea, but certainly some sort of peer comparison would be interesting. Also, how people compare in terms of making their appointments. I think the real big area that's untapped is social supports. The idea of creating maybe adherence competitions among our families or creating platforms for peer support. An untapped kind of interesting area. Almost done. We're going to close with two areas of how these concepts can be leveraged with health IT, and then we'll talk about some of the limitations and then have time for some Q&A. So anyone in the primary care setting has seen this on a regular basis, but it's such a good example. This is an example of our care assistant, clinical decision support tool targeted at clinicians, at the physicians and nurse practitioners around vaccination. And what this shows is defaulting the vaccines that are due and presenting those to the physicians across a wide range of types of appointments leads to a dramatic increased likelihood of individuals receiving their vaccines. In fact, the early studies by Alex, Bob Grummeyer, other people on this phone call showed a significant more than 8% increased likelihood that the children successfully received their vaccines, a huge clinically meaningful difference. Something recently, this is unpublished data, but this is based on work in our CHOP Care network. You can go further, not just with how you present the vaccine within the electronic health record framework. You can also change the default in which you offer things. One of the things we were struggling with in our CHOP Care network was we were doing well, but not as well as where we could be in terms of HPV vaccination. This is early data showing most children initially were offered the vaccine at age 11. Newer data suggests that offering it down to age 9 is a more effective approach, might actually boost the immunogenicity of the vaccine, but also might bypass discussions about some of the barriers of why people may not want to receive the vaccine. So we shifted the default in which it was offered. And what we're showing you here in a run chart, that shift was associated, this is a randomized control trial, but it was associated with what seems to be a 30% increased likelihood of children actually receiving the HPV vaccine. So again, it shows you the power of defaults. We did work around parent smoking, where we combined a couple of these core ideas and of defaulting, overcoming present bias to really help the pediatricians treat parents that smoke and then get those parent smokers engaged in treatment. This is just showing you a couple images of the clinical decision support tool, prompting the physician to ask, and then showing you the orders that made it really easy to default referral to a resource called the Quit Line, a free service that's available in the community that's been shown in multiple studies to help people quit smoking, and then prescribe medication for that parent and then document it. So we made it really easy. And we studied this in a pragmatic randomized control trial. What we did is we took parents, 500 parents, randomized them to one of two options. So the tool helped prompt this, and then this was the added intervention, to either e-referral, overcoming present bias. Parent wanted to get connected to the Quit Line, but often didn't. So what we did was the Quit Line would call them in 24 hours to start care. And we randomized, compare that to the standard approach, which is for so much of care. Well, here's something and you go call it. And we looked at outcomes, Quit Line enrollment, and the number of calls. And we defaulted to make sure that all the parents actually received nicotine replacement therapy, patch and gum. And we found fascinating results. In the e-referral group, there was a 5-fold increased likelihood that the parents would successfully enroll in treatment. And not only did they just enroll, they had a greater number of sessions. So they took the first steps towards kind of ultimately quitting. And dramatic power, of defaults, with that offering that nicotine replacement therapy prescription, more than 85% of parents walked out of the office with an NRT nicotine replacement therapy prescription. Prior to this, the typical kind of approach is zero, meaning 0% of parents would actually receive that prescription. So again, shows you how these can be incorporated with health IT. Another interesting area has been using CDS tools to create active choice, enhanced active choice scenarios. And a lot of this work has been done over at Penn, where they use electronic health features to identify key patients, prompt an accept or cancel decision. You pre-select key actions, and then you provide important information to help guide the decision. And these are often, for those with expertise, we tend to refer to these as kind of best practice alerts. But you have to make sure you design them in the right way that really prompts the choice. And there's been multiple studies that have shown that they improve adherence to a variety of care area guidelines, increasing physician ordering and patient engagement when it comes to colonoscopy, making sure that it's actually referred and provided by the physician, and then the individual actually follows up with it. Tobacco treatment, I'm just showing you a screen grab from some of our work around within the cancer center, helping individuals connect to who smoke, connect them to treatment, and then influenza vaccines. So this again shows you kind of the interesting use of this in health IT. One last area that combines clinical decision support within the health record plus decision support targeted at the family. This was work published in Pediatrics from Alex Fix and his team, show that the combination of decision support targeted at both the family and the parents, at the family, parents, and the providers, the orange bar is showing you that that combination led to a dramatic, significant increased likelihood that those individual patients received the HPV vaccine. I want to close this section by just highlighting how we could probably be leveraging these ideas with new technologies that extend from our electronic health record. And one of the core untapped areas is text messaging, showing you kind of a survey from the Pew Research Center in which they've identified over time that the vast majority of Americans have access to cell phones. More than 75% now have access to smartphones. And that's pretty consistent across race, ethnicity, socioeconomic status, and education level. So we wanted to kind of play on this with some of our work in the child care network, get people re-engaged who were overdue for routine well visits. And what we did was we took text messaging combined with an active choice argument presented to the individuals. What we did is we took 150 patients overdue for well visit, and we pilot tested the idea of texting them to get them re-engaged for care. And we sent them a series of texts, but this was the core one, essentially saying, we miss you. We need you to come back in. Would you like someone to schedule it? Do you wish us to call you? Do you want to call us? Kind of presenting the options, but essentially not presenting not doing it, never presenting not doing it as an option. And we found some interesting results. First, in terms of well visits, of these people, this group of patients who were overdue for well visits, so already had poor adherence, we were able to get 40% of that population scheduled for a well visit, and then 70% of them actually completed it. We also found an interesting side note is that 13% of our patients of this group were no longer our patients. So we could actually kind of remove them from our panel, which leads to kind of helps us focus on the patients who are actually our patients. And when we modeled this out across the care network, we found that this could lead to a 5 to 7% increase in completed well visits. So kind of an interesting opportunity. So that just gives you kind of a flavor of the different options. Now, I just want to close with talking about some of the limitations and then the final thoughts. Now, in terms of the limitations of behavioral economics, people smarter than me have written about this, and I'd like to kind of highlight some of the core areas. Behavior change is hard, period. So we shouldn't think that simple things are going to dramatically change everything. There have been significant gains in using these concepts around, like I mentioned, financial savings, public health, vaccine rates, and smoke cessation. There's been mixed results when it comes to medication adherence, and I guess unsurprisingly, using these sort of techniques has shown to be not really effective in obesity treatment, but frankly, there's been very few things that are effective in obesity treatment. So that's the first thing. Behavior change is hard. The second thing we should always watch out for is not letting policy get ahead of the science. And this next point really frustrates me. So there's this idea from research about 20 years ago that started that if you post calorie counts on menus, people are rational and they're going to choose the healthier options. That is not true. There are multiple studies that show that's not effective in changing food order. In fact, in more vulnerable populations, in underserved populations, the exact opposite might be happening. When people see calorie counts and they see kind of the calorie count, more calories for a cheaper option potentially, they can avoid the idea of, well, there's more bang for my buck. I'm going to go with the kind of the potentially what we would view as the worst option. Nonetheless, there's a whole section and a scary amount of money allocated by the FDA to continue to put calorie counts on menus. So that's a poor example of policy getting ahead of the science. And then the last area, in terms of broad limitations we should watch out for, is not letting nudges, this helpfully, these kind of guiding people in the right direction, becoming shoves. And something I was very frustrated with is that financial incentives seem to work to help individuals quit smoking, that kind of carrot option. The companies that first piloted this work, rather than actually offer financial incentives to help people quit smoking, when they enacted the policy, they shifted them to sticks, that instead of financial rewards, they became penalties. If you're a smoker, you're going to have to pay X amount more compared to the non-smoker. And that's not what the research shows, and that's not what we're trying to do. We're trying to help people make better decisions. We're not trying to be punitive. When we think about the limits, when we combine this with health IT, I think I want to close with these points. There are multiple conversations and multiple presentations that could be had around the frustrations with our electronic health records. There are clear issues with usability, and I would say there's a failure of choice architecture of really helping design the best options for us as physicians, for our providers, and for our patients. So for all of us who might be involved in this sort of work or getting interested in more involved in this work, we should use these principles to guide these nudges. And I'm adapting this from Richard Thaler, kind of applying this to health IT. Any nudge we do, any decision support, anything we push people towards, they should be transparent and never misleading. It should be clear as to why we're doing this. The next one is you should make it as easy as possible to opt out of a nudge. When it comes to health IT work, ideally one click. Right? If it makes it really hard, that's not the point of this sort of work. And finally, there should be good reason to believe that the behavior encouraged will actually improve the welfare of those being nudged. We shouldn't spend time on decision support that's not actually, we're uncertain if it's actually going to, if the outcome is the outcome we want. We should really focus on the things with strong evidence to support the decision making. So with that, I'll close back to that image I showed you before. We can do better in presenting choices to help people make better decisions. So I start with this kind of picture of people using the escalator where they should be using the stairs, and close with a really fascinating example from Stockholm. What they did was they had people in a subway system, same time of the year, they were get out of the subway, get out of the public transit, and they would use the escalator. Overnight, same time of kind of year, they switched the staircases to piano staircases. They were really fun to walk up, you can make sounds, and as you see in the pictures, where on the left, everyone used the escalator, and they found this still when they followed up with it. The vast majority of people were using the stairs because it was a much more fun thing to engage with. It helped people make better decisions. All right, with that, I'll close.
Great. Thank you, Brian. And we want to give you another virtual round of applause for really an excellent presentation. We really appreciate it. I want to encourage everyone to put in your questions into the chat window, and Brian will hopefully address them for us. We do have, at least another 8-10 minutes before the beginning of the hour. So again, thank you and really appreciate it. And I have one of my questions is already in the chat window. So thanks again.
Yeah, and that's a great question, Tony. I think it's I don't have a perfect answer to it. So I'll kind of read what Tony said was, what are the strategies for effective healthcare messaging to our parents, patients when they're bombarded with so many conflicting messages in media, social media, et cetera? That's a great question. I think I can give some things that could help with this. I think the first thing is we need to start competing, meaning we should be pushing out some of the messages. And there's been appetite for that, and we could probably be doing that more coming from our offices, for example, reaching out to families. Because the second point is there is strong data that shows that when guidance is coming from the trusted resource, from the pediatrician, it can overcome all that noise in the background, for example, around vaccines or inappropriate COVID treatments, et cetera. So that's a good one. All right, hi, Linda. I'll go to Linda's. What are some of your thoughts about the balance between individual's agency and the opt-in approach for many behaviors? Or an individual choice even better when there's a better choice? So I think getting at is this idea of when to use defaults and then the active choice. I think what that's getting at. And what we could imagine is maybe a tiered approach where we can have, the certain approaches where there's the best option, and then there are next best options. And what would be great is, I think there's a lot of autonomy, and there's some evidence to support this, that if you help a family, a patient, make at least that one next step, even if it's not the one that we ultimately want to start, but it's on that continuum, if we can design situations where they at least take that next step, then we can kind of play off that and then help guide people towards ultimately kind of better decisions, if that's answered the question. And then the last question so far is there data to show adolescents respond in the same way as adults to these prompts? Great question. There is. There is data that shows, for example, around teenagers are even more present bias than adults. So there's kind of information there, but they're not entirely irrational. They can make decision making. So there's work that shows that flipping how teenagers kind of focus, helping make things more salient to the present. There's a lot of work around drug management, for example, not focusing on the fact that if you smoke, you're going to die from cancer 50, 60 years down the road, but instead talking about what's happening to you right now. That can increase the likelihood that teens go on to quit or certainly not engage. There's also some pitfalls there because you have to be careful how we design their work. There's been several studies looking at the use of financial incentives to guide teenage behavior in certain directions, and you have to be careful of what you're incentivizing. So, for example, colleagues did a financial incentive study to help with type 1 diabetes management for adolescents. Small payments to make sure that children were more often checking their blood sugar. They found that sort of system, the teens led to an increased likelihood they'll check their blood sugar, but they were actually gaming the system a little bit. They led to no meaningful impact in the likelihood that they actually be more adherent to their regimen. That they focused on the target, they were incentivized towards that, but they kind of bypassed what the actual outcome was. So there's some data there, but I would say this is a wide open field and we should be consider using these for teenagers because so many of the behaviors that we're trying to overcome later on in life start during the adolescent years. There's another great question about, I'll read this one because I think it captures it well. And I think we'll have time for maybe 2 more questions. It seems like the nudges work well for binary yes/no outcomes. For a continuous variable, how do you nudge towards a continuous variable goal like BMI? Does it need to be turned into numerous binary outcomes like attending an obesity clinic? I think you answered the old question. I think obesity treatment is tough. when we think about why I think so much of this work has been powerful in smoking, and I don't want to undersell how difficult it is to quit smoking, difficult it is to kind of fight back against an addiction, but it's the removal of a situation. So that's different than obesity management, which is like constant having to make good decisions. So the hope is, could you turn what feel like insurmountable continuous? I like that suggestion, turning them into kind of more binary yes, no, and helping with active choice along the way. And I think this might be our last question. And I think this is a great one, and I want to speak to this one. So let me read this as well. With default options, what this essentially question is asking about is what are the ethical implications of this? Right, we can focus on defaults, but are we kind of removing people's autonomy? And I think that's something that we need to continue to think about and work towards. That's why I think us in the pediatric space should really be diving into this. So when it comes to using defaults for vaccines, I think we can justify that. The vast majority of people want these vaccines, and they're critically important to protecting long-term health, both individual health and community health and population health. But when it comes to things that are less clear, for you, and I showed you at the start of the presentation, end-of-life decision-making, I think we should be really careful about how we best present these and not making opt-outs that are so restrictive that people can't actually opt out of them. And I encourage people who want to talk more about this, happy to talk more offline and think about ideas of how we set it is. We have 2 more minutes. If there's one more question. Otherwise, Tony, looks like no more questions in the messages. Tony, I can hand it back to you.
Great. Well, thank you again, Brian. And I just wanted to remind everyone, if you would like any kind of continuing education credits, whether medical or nursing, feel free to email Mark Diltz, and his email address is in the chat window. And again, just another round of applause for Brian for an excellent presentation. Thank you, Brian.
Thanks, everyone. Great questions. Again, if anyone's interested in talking more about this, happy to. All right. Thanks, everyone. Stay safe.
Thank you.